Again, good morning and welcome to this clinical education program, which is entitled Osseointegration in the U.S., Prosthetic Implications for Today and Tomorrow. My name is Charles Kuffel, and I'm pleased to serve as your moderator this morning. In this program, our panel will discuss the past, present, and future of osseointegration. This presentation will begin with the history, outcomes research, risk benefits, and resources for patients. A surgeon will present surgical considerations and procedures and then help you realize the rehab required, complications, cost, payment to OI, the prosthetist considerations for patient selection, alignment, device selection, complications, cost payment challenges, and a future look at the prosthetist role for OI procedures. This program has been approved for 1.5 CE credits, so I'm a professor of family medicine at the University of Colorado School of Medicine. Dr. who is an associate professor in the Department of Orthopedics at the University of Colorado School of Medicine. He is the Vice Chair of Clinical Affairs, Chief of Orthopedic Trauma and Fracture Surgery, and Director of the Multidisciplinary. He specializes in the treatment of simple and complex fractures, non-unions, malunions, salvage, and osseointegration surgery and amputees. Our final presenter today will be Christopher Hoyt CP, who is a graduate of the UCLA Prosthetics Orthotics Education Program in 1983. Hoyt worked as the UCLA School of Medicine Clinical Laboratory for a few years, prior to being hired as a senior instructor with the education program. He maintained a private practice during non-teaching hours. While at UCLA, Christopher developed a quantifiable, teachable approach to ischial containment, and since then has educated more than 1,800 prosthetists in 28 countries via hands-on seminars. Please, I'd like to introduce Dr. Jeffrey Cain as the first presenter. Thank you.
Doesn't it seem like we're seeing osseointegration everywhere right now? If you turn on your television on Sunday morning on CBS, you're seeing CBS osseointegration. If you got Amplitude, the magazine that went to every one of your patients, the cover story is about osseointegration because they cover osseointegration. If you look online, this is a prosthetist office advertising their practice because they cover osseointegration. Maybe you got the O&P Almanac in the mail or in your bag right now, and you'll find that the cover story is about osseointegration. So we're excited to talk with you about osseointegration because we think osseointegration is a big thing coming. Right now, there are only 2,000 people in the world living with osseointegration. And in the United States, there's only 500 people that are living with osseointegration. Why should we talk about it? Number one, because there's been a device that's been approved by the FDA, and they're talking to your patients right now. Number two, there are 3 or 4 new devices that are in the process of being evaluated and approved by the FDA. So we think that this is, for the right patient, transformative for their lives. So my name's Jeff Cain. I'm a family doctor at the University of Colorado. I've been the chair of the Amputee Coalition, and osseointegration is a particular interest of mine. Our hope with you today is to do 3 things. Number one, if you're a prosthetist sitting in the room and your patients talk with you about osseointegration, I'd like you to know what the science says, where we are right now, so you can accurately answer their questions. Number two, if you're a prosthetist sitting here that thinks, oh man, this is exciting, I want to be part of this, what's it take to be able to take great care of people with osseointegration? Chris is going to talk with you about that. If you want to understand the surgery, Dr. Stoneback is going to be talking to you about that. And the third thing that we really need to do is to talk about as an industry, as an organization, as people living with limb loss and people that are in the industry, what do we have to do to make certain that our country is ready with rules and regulations to reward and value the work that you do? Because I believe that the prosthetist is probably the most unrecognized, critically important person that is really going to be able to help people be very successful with osseointegration. So, in the next 15, 20 minutes, I'd like to talk with you a little bit about the background of osseointegration, what it is, where it came from. There's some great studies that have come out in the last few years that I hope will help you understand that for the right patient, there's some things that you can know about what helps osseointegration make their lives better. I'd also like to close in with a case presentation because how can we talk about something that affects patients without talking about a specific patient? So, So what is osseointegration? This is a complex answer, but the person that created osseointegration is Dr. Brandemark, who says that osseointegration is the structural and functional connection between the macroporous surface of an implant and living bone tissue percutaneously that's attached to a prosthetic limb. That's a lot of words, isn't it? But what that really means is osseointegration is a different way to attach a prosthetic for a person that's an amputee that's having difficulty with a traditional prosthetic socket. Now, anybody in here ever have a patient with a difficulty with a traditional prosthetic socket? Every person here in the room. What are the problems you have? That's uncomfortable. There's a skin graft underneath there. There's pressure on a nerve. The stump is, the femur is really short. You can't get it to stay on. They sweat and it falls off. All of those things are gone. The next thing that happens is that actually changes the way the body uses the prosthetic, especially for an above-knee amputee. If you look at the person that's in the socket, you know the femur is sitting there floating in the bucket. The other thing that happens is the alignment of their skeletal alignment is different. When you change to the prosthetic on the other side of the photo, that is an osseointegration, you can see an anatomic alignment of the femur, and they're going to be using the intrinsic muscles of their hip the way that they were intended to be used. The next thing that happens that's really important for your person that lives with osseointegration is they can take that prosthetic on and off about that fast. Literally, it's connecting. There's an adapter. It's either a wrench or there's a quick connect. It comes on, it comes off, and every time it goes on, it's on the same place with the same alignment. So there's some things that when you talk to people living with osseointegration that will tell you that are benefits of having that prosthetic directly connected to their skeleton. You eliminate all those skeletal, all those problems you have with the socket. There's something that's called osseoperception. Because they're connected directly to their bone, they feel things differently. So when they're walking, a person that's above knee will say, oh, that's grass, that's gravel. They have a different kind of connection that it feels like it's part of them. When you do studies, we'll see in a few moments that people that wear osseointegration will tell you that they have a different quality of life. It improves their gait and their step count. They wear their prosthetic, they put on in the morning, and they take it off at night. There's also some surgical risk, though. This is a big deal surgery, and Dr. Stoneback is going to go through the risks, but they're the things that go along with a large, big surgery, but also things like this, the implant can loosen, there can be an infection. You have a piece of metal going through your skin, so you have to learn how to do the care of that stoma there. There's pain when you have surgery. There's also an expense with that, and then Dr. Stoneback is going to talk specifically about those things. Then there's the things that everyone here in the room wants to know about how do we do this prosthetically, and Chris Hoyt is going to be able to talk about that because Chris has specialized in osseointegration. But one of the things that you need to know is that when you wear an osseointegration implant, that there's really contraindications for high torque and high impact activities. Things like skiing or running may put that implant at risk. You really got to line it well, because if you misalign it, there's no slot built into the system. So alignment on a BK means that they're going to have normal wear or abnormal wear of their knee. Remember we said osseoperception is a cool thing for people? It also is hard for people too, because they may feel more things, they may feel vibration when they're out driving or something like that. There's some controversy about whether a person with osseointegration should go in a swimming pool, specifically swimming pools or stagnant water because of the risk of infection. And the other thing that seems obvious, but there's going to be a piece of metal sticking out of their body for the rest of their lives. And that's something that's different that people have to get used to. So how did this come to be for prosthetics? Remember that Dr. Brandemark that we talked about that invented this? He started actually with dental implants. That microporous feature in the screw implant that you all know that's happening in dental schools and dental practices throughout our country was the beginning of osseointegration. And what happened when that started? They started putting those in, they were failing all the time, and then over time, the devices and the surgical techniques improved, so now it's being done literally right around the corner from my house. Now, making the switch from teeth to legs, Dr. Richard Brandemark is the son of Per Brandemark, who invented the AOPA screw implant. It uses similar technology. It's screwed into the bone. You'll hear specifically how that surgery is done in a few moments, and he's in Sweden. His surgery is a two-stage surgery where they put the implant inside and then later connect the abutment that connects you to the outside of the foot. It has a protocol about how long it takes. Full activity return is somewhere between 6 and 12 months. And again, you're going to hear more about the rehabilitation of each of these later. The next stage, another stage in osseointegration, is there are other kinds of implants that we use in our bodies. Horst Aschoff thought, why not think about the same technology that we use to put in an artificial knee or artificial hip, which is a press fit device. It's not screwed in like the AOPA device is. And he invented that and used that in Germany. That was further developed by Doctors Frolke and Van de Meent, who are in the Netherlands, who not only had modifications of that press fit, but they were the ones that really focused on, for press fit implants, using a team approach with rehabilitation, with a prosthetist on the staff and physical therapy as part of the package. They've also done some excellent studies that we'll talk about in just a few moments. Dr. Munjed Almaderis worked with these and then further progressed in terms of his modifications of those implants. And one of his modifications was to be able to do this surgery in a single stage, to put the implant in and then let people gradually start walking on a graded way very early in the process, again with a large team. Dr. Almaderis has done 1,200 cases, which is out of the 2,000 in the world, he's the leading surgeon in terms of numbers. So I just talked about a bunch of different systems. And you got to remember, right, all these different systems, you got to think about, oh, there's also there's a compress system that's in the United States. No. I think you really want to think about, if you're a prosthetist right now, is there's two kinds of devices. There's the AOPA screw device, and there's the press fit device, and there's about 2,000 people in the world that have had this procedure. And the things to remember about the screw fit device is it's FDA approved. The thing to know about the press fit is it's undergoing investigational trials right now in the United States. And there's some differences in the rehab that I'm going to skip over and defer to Dr. Stoneback. Now, the AOPA implant system is from the Integrum company. You can see by the dots there, they have surgical centers across the United States. And if you're interested in Integrum, you go through their main number to be able to connect with those. If you're interested in the press fit devices, there are several surgical centers that are doing this in New York. There's one in Colorado, that are at the University of Colorado. And those can be found but through the Amputee Coalition's list of osseointegration contact information or for online searches. There is lots of online activity about this activity. So we talked a little bit about what it is. I'd like to tell you a bit about the proven benefits. You probably have heard some patients read about things on Facebook, and sometimes it sounds it's almost zealous religious in the way people talk about it. There's a science behind this that I hope people will be able to understand now, that because we've been doing it for over 20 years in Sweden, they've been doing it about 10 years in Australia, and so there's data behind this, not just patient cases. So this is an article literally from this last June from the European Journal of Trauma and Emergency Surgery, and that what they say that when you survey them using the standard things that we do to survey people that wear prosthetics, the TOPS attachments, shows higher scores for mobility and patient satisfaction. Some of you might have heard of a guy named Bob Gailey. Bob Gailey is my favorite physical therapist. He teaches people how to run that wear a prosthesis. Bob Gailey gave a presentation at this very conference that says that when somebody has good osseointegration, that they are the same or better as someone that has an excellent prosthesis. Notice that's the best prosthesis, not someone that's having a problem with their prosthesis. This is a journal that actually says, why do people do better? This is a journal article that's just come out recently that talks about August of 2022. I hope that's recent enough for the people in the audience. One of the explanations for why it works better is when you have a femoral amputation, you're actually biomechanically getting to use the muscles that were designed to be able to drive your femur, and that helps you get in and out of a chair in a way that's significantly different and may contribute to long-term better outcomes. But what about other kinds of studies? We oftentimes use the 6-minute walk test or maybe the timed up and go test. This is a study from the Dutch team that shows the 6-minute test, the timed up and go test, and even the percent of amount of oxygen that you use are better and improved compared to a traditional socket for above knee amputees.
In other words, an above-knee amputee that has osseointegration use 18% less oxygen, less energy for every step that they take. That's a significant difference in why people are raving about it that wear that. So, yeah, but these are just run-off studies, right? These are just 1 year or 2 years. How about a 5-year retrospective study? This is from Australia, and this is 93 patients. And out of that full series of 93, at the end of 5 years, they were all still wearing their implant. However, there were some complications, that there were 19 different surgeries for revisions for this is the press fit implant, and there were 43 infections that required surgical debridement. Now, some of those were multiple in the same patient, but it's important to know that for the right people, they are still wearing their prosthetic even with those complications. Yeah, but is this going to be something that really is accepted by the House of Medicine? It's weird, it's unusual. How about the Journal of Bone and Joint Surgery? In their conclusion, they did a system review. What that means is that they looked at all of the papers that was available out there to look at the risks and benefits of osseointegration. And their conclusion is that osseointegration for limb amputation has become an established clinical treatment option for persons with lower limb amputations not tolerating traditional socket prosthetics. Osseointegration should provide substantial benefits for function and quality of life for appropriately selected patients who accept the documented risks. Again, documented risks like any surgical procedure. So, we talked a little bit about what OI is and a little bit of the history of OI, a little bit about the research. Let's talk about a specific patient. I'd like to introduce you to a 63-year-old male that had bilateral osseointegration almost 6 years ago in Sydney, Australia. How'd this come to be? This person had a multi-trauma airplane accident. He woke up in the intensive care unit with about every facial fracture that you can imagine, on the ventilator for 2 weeks, crushed hands, arms, chest, crushed legs. This is a crushed calcaneus, a tib fib, partially fused midfoot. That's the foot that he got to keep for 5 years. The other one was amputated while he was in a coma. And he discovered in the course of his recovery that his good leg was his prosthesis and had that electively removed. Well, how did he do as a bilateral? He did really great. He had excellent prosthetic care. He had his left BK in 1996, his right in 2001, and he returned to an active lifestyle, which included racing nationally on a snowboard, demonstration water skier for Disabled Sports USA, flying small airplanes. He was promoted in his work to be a clinical professor of medicine, was president of the American Academy of Family Physicians, and was the board chair of the Amputee Coalition. That's me. Why would a guy that was doing great in sockets choose to go through this big surgery? Because I'll tell you, prosthetic sockets work great until sometimes they don't. So in my own personal case, what happened is that I had a problem on the inside flare of my tibial flare, and that pressure there and sympathetic feedback meant that I had a hard time. I was having pain and sweating that went from doing triathlons to having me able to walk or stand less than 2 to 4 minutes, walking less than a block. When I would go to a park with my girlfriend, I'd bring a chair and I'd read a book and she'd go for a walk. When I would go to see patients in my office, I would drive to the office, get my wheelchair out, take my leg off, see patients in a wheelchair with only one prosthetic leg. When I would want to go flying, one of my hobbies is to introduce young people to aviation by giving them their first flights, and I couldn't do that because I couldn't walk the kids to the airplane and back comfortably. So I did a few things. I didn't just jump at this. I spent 2 years, saw 4 prosthetists that you all would recognize by their face and names, had 30 check sockets, 4 interface systems, 5 orthopedic surgeons. I had my leg injected. I even went as far as I tried Chinese herbal medicine, and nothing was happening. And when I was at the Amputee Coalition meeting in 2016, for the first time ever, I watched a young woman walk by that had a below-knee osseointegration, and I went over, I said, wait, osseointegration is in Sweden, it's only for above knees, it fails half the time. And she said, nah, that's old news, Jeff. Come on down, I'd like you to meet a surgeon. So I went down and met the surgeon that's in Australia, Dr. Almaderis, and it wasn't enough to listen to him and that team. I came to this meeting that we're at right now, and there was a presentation that had, let's see, Dr. Almaderis, I think you guys might recognize some of these names, Dr. Brannemark, Horst Aschoff, they were on stage, and I set up meetings with each of those. I talked to the researchers in the United States at the University of Utah in Pittsburgh. I commissioned a research person to be able to do research about what osseointegration does for below-knee amputees. And I contacted 12 different people that had BKOI. And I pulled the trigger in December of 2016. I went down to Sydney to have the surgery, and everything went great, right? What complications that I mentioned could happen? Okay, I had a skin infection while I was down there after they did it. I had to have a debridement procedure from a deep tissue while I was there. I had to be on IV antibiotics and came home to be on 3 oral antibiotics for a year. That was the first year. 2 years ago, I was doing great on the osseointegration. 2 years ago, I started to have another infection, and I had another hospitalization here in the United States that involved IV antibiotics and debridement and another surgical recovery. So how did I do? How was that? One of the lessons that I learned in my path, this is Pat, my girlfriend, she would say, don't ever ask the person that chooses to do a procedure where you have to fly halfway around the world and pay for it yourself, because it's not in the United States. Don't ask that person, ask their partner. So what do? You ask Pat, and Pat would say, before I had the surgery, I was always in pain. I would try to hide that pain, but she could see it in my face. If I walked into a room, I was looking for a place to sit down. Now, she says, when I go out and shovel snow, I can feel the snow crunch underneath my feet. She tells me that I'm not as hot as I used to be. I hope what she means is that I used to have essentially like a wetsuit all the way up to my waist all the time with the vacuum systems that I was wearing. I hope that's what she means. But I also know that there's a couple things I don't do as much anymore. I've given up downhill skiing. I raced nationally before and medaled with a snowboard nationally, and I don't do that because that's impact activity that I think would put that at risk. I quit swimming in swimming pools. I don't go swimming in lakes. Unfortunately, my girlfriend said she was hoping my sense of humor would change. It's still the same. So what's that mean to me? What it means to me is when we go to a national park, I don't sit in the car anymore. When we go to Hawaii, I still go snorkeling. I go out there and I'm looking at the fish along with her. I might not do downhill skiing anymore, but I'm a cross-country skier these days. That's not really skiing, it's really jogging in the snow. But it is skiing, it's being out there. I'm back to flying kids in the airplane again. I like to tell people my little Piper Cub isn't the fastest airplane in the sky, but I get there with the fewest number of legs. Sorry. Oh. And I think it's also improved my handicap. Oh, sorry. So what I'm hoping that you guys will understand is that this is actually a procedure that has a track record, it has a research behind it. If you'd like to learn more about it, open up the issue of your O&P Almanac that's in your handout right now. If your patients want to know more about it, the Amputee Coalition has an online fact sheet. I think the independent resources like the Amputee Coalition and the Walter Reed's website are perfect. Be careful on the Facebook pages because they tend to be full of people that are that have their own opinions of the N=1 of their study. I want to know about what it's true across the population. So what I'm hoping that you guys are understanding is that this is a procedure that is here now, that has a potential for huge growth right now, and for the right patients, not for everyone, but for the right patients that are having difficulty in their socket, this procedure is transformative. So thank you for your time. I'd like to introduce Dr. Jason Stoneback.
Thanks, Jeff. That's great. Great segue into, let me open my. Okay. Thanks, Dr. Cain. That was a great introduction. So I'm Jason Stoneback from the University of Colorado, and I'm an osseointegration surgeon. So my job is to take you to the operating room today. So we're going to go and see what it's like to do some of these cases and point out some of the things that are important in patient selection. And it is really imperative that the prosthetist and the surgeon are communicating, because there's a lot of planning that's involved with existing componentry, leveling knee centers, etc. Disclosures. So I won't belabor these points. All of you are well aware of the issues with socket prosthetics. While many patients do well in sockets, there are some patients, like these patients with these large soft tissue, redundant soft tissue envelopes or lots of scarring and skin grafts, may have difficulty doing well in a socket. And it's those patients that we want to figure out who they are and select that patient population for evaluation for osseointegration. Dr. Cain already talked about the origins of this with Per Ingvar Brandemark and dental implant technology. And so really it's allowing, from an orthopedic surgeon's perspective, what we're doing with osseointegration is integrating that implant into the patient's skeleton and allowing us to harness their musculoskeletal system. That means everything from where the loads go through their joints, leveling their pelvis, allowing them to use all of their musculature as it was intended before they're an amputee. The benefits of osseoperception, being able to feel where their limb is in space and having improved walking mobility and confidence in their walking and overall improved quality of life is just super impactful for the right patients. So what are the different implant techniques and technologies? So the first is a screw-type implant, which is the AOPA device that came from the dental implant technology. So if you look at the implant, which we refer to as a fixture, it is designed to go inside the bone into the intramedullary canal and is designed specifically to be countersunk. And you can see there's an end there where we actually bone graft the femur to seal the canal and create a surface that we're able to put a skin graft or a full thickness skin graft when we come back and do the second stage. So this is what it looks, a schematic of what it looks like during the first stage using the AOPA device. It's the only FDA-approved device in the United States. It is a two-stage only type of device, meaning you have to have two surgeries in order to perform it. And here are some of the criteria that are required to use this device. The patients have to be between 22 to 65, have to be less than 220 pounds, including their prosthesis, and they have to have at least 2 millimeters of cortex that is surrounding the implant after it's been implanted. There are certain lengths. The device itself is 80 millimeters in length, but you need a little bit more than that to adequately countersink it for a successful stage 2 in the traditional sense. There are various diameters available as listed here. As I mentioned, it's a two-stage technique. There's 6 months per the instructions for use and FDA approval between stage 1 and stage 2. However, Walter Reed has decreased that to around 3 months, and some surgeons are doing that in an off-label manner. The rehabilitation after the stage 2 procedure is the patient is non-weight bearing for a period of 6 weeks, and then they go into a short axial loading device where they do axial loading only for 4 weeks, followed by a longer axial pylon for 4 weeks, and then they're introduced to their prosthetic limb and begin ambulating and progressing with loading and weight bearing with the goal of walking unassisted by 1 year. Here's a case example that we performed. So some of the things that we look for are overall length, quality of bone, and alignment in their preoperative evaluation. As a surgeon, and this is important that we partner with the prosthetist, we have to plan not only where is the resection of the bone and how much we shorten them. There are a lot of factors that play into this. How much soft tissue we have for coverage, the quality of the bone. You can see the canal here is sort of circuitous distally, so that's not a good section of bone to perform osseointegration. So there's a lot of planning that goes in the preoperative stage for this. So stage 1 is pretty straightforward. We open the existing soft tissue envelope, prepare the intramedullary canal, and implant the device. we bone graft the end of the device, as I mentioned previously, and so that we can seal that canal, close the soft tissue envelope, and then, as I said, it's 6 months between stage 1 and stage 2, where during that time point, osseointegration occurs. During that time, patients can wear a socket. However, due to various issues, one is insurance. Patients rarely wear sockets in between that time. We do perform routine radiographic evaluation to ensure that the implant is successfully osseointegrated before moving on to stage 2. The stage 2 procedure is actually the larger procedure. It's the creation of what we call a fasciocutaneous flap. So it's a large soft tissue envelope that we elevate. We create what's called a muscle platform, where the muscles are attached to the bone, about 1 centimeter proximal to the distal end of the bone. And then we thin out the soft tissue envelope where the skin penetration site is to create a full thickness skin graft that then grafts itself and attaches itself to the bone distally, and of course bring the abutment or the percutaneous portion of the implant through the skin. A critical time point here, and you can see we're putting on a nitro paste, is this large soft tissue envelope. We want to be very cautious of this area as it can be prone to necrosis. So that's what if everyone's wondering what that white paste is, putting that on to help mitigate that risk. During the initial 6 weeks after stage 2, it's critical that we don't have a lot of motion. We want that skin graft to take and the soft tissue envelope to heal. And we want to watch the skin grafted area of the skin penetration site and that watershed area that may have compromised blood flow. If all goes well, and which it usually does, or very often does, then the patient looks like this postoperatively. The other main technique that's used worldwide is the press fit technique. As Dr. Cain mentioned, it's centered around like hip replacement type surgeries, something that orthopedic surgeons are very accustomed to dealing with. Currently, the majority of cases being done are in femurs and tibias. We have the ability to do these under a custom device exemption and with the FDA, and to accommodate very abnormal anatomy. So it's a real powerful tool. It can be done in femurs and tibias can be done in a 2-stage technique or in a single-stage technique. And they're with 6 weeks between stage 1 and stage 2 if it's done in a 2-stage technique. The rehabilitation protocols are very center specific. Some advocate initial weight bearing immediately after a single stage procedure, or others wait 6 weeks. Our program waits both 6 weeks for both femurs and tibias, and have had good success with that protocol. The goal is walking unassisted, without assistive devices, 3 to 4 months after stage 1. So what does that look like? There's obviously the initial evaluation, a hospital stay for about 2 to 3 days if we're doing a 2-stage technique. This is what a first stage press fit osseointegration procedure looks like for a femur. We remove redundant soft tissue, muscle, with a pre-planned osteotomy level to assure that we have good knee centers and can accommodate the appropriate componentry below the device. After we remove the redundant soft tissue, and we prepare the canal, and then also prepare sites where we create a myodesis, where we reattach the muscles so they have good control of the limb postoperatively. After the implant is impacted into place, the soft tissue envelope is then, the myodesis is performed and the soft tissue envelope is closed, and the patient then waits 6 weeks before returning for stage 2. The stage 2 procedure is an outpatient procedure. And this is what that looks like. We create the stoma, where a skin penetration site is what we call the AOPA skin penetration site. The equivalent with press fit device is called a stoma. We create that stoma and attach the percutaneous or transcutaneous component, which is called a dual cone adapter. And then the patient starts walking in our practice 48 hours after stage 2. There is also the ability to perform this in a single stage technique. Tibias, in my practice, we perform all tibias in a single stage technique due to the very small soft tissue envelope. So it's very similar to the first stage with femurs, except everything is done at once, including stage 2, 2 to 3 day hospital stay. This is what that looks like intraoperatively. We prepare the canal and then implant the device, then bring the implant through the skin at the same time, creating the stoma during that single stage technique. We still wait 6 weeks before allowing them to load, okay? So here's a couple quick case examples. Patient of ours with terrible pain, unable to pick up the mail. I asked her, why do you want osseointegration? She said, I want to be able to hold my grandchildren's hands as we cross the road. These are not unreasonable expectations. So here's Donna, which many of you may recognize her on the cover of the magazine Dr. Cain mentioned. And here she is after post-stage 2, going through rehab, and she can now just clip on and clip off her prosthetic limb. One of her biggest concerns was her inability to sit for prolonged periods of time at dinner with family and friends. Now, with that socket gone, she's able to do that. So she can do the things that she wants to do, include horseback riding, which is a big deal to her. Another patient. So this particular patient was unfortunately sustained a gunshot wound to her leg, lost her limb, was a below knee amputee, was having all sorts of difficulty, just wound breakdown, constant pain due to the skin graft. You can see this is definitely a complex soft tissue envelope. So she was not wearing a socket at all and had given up on it and was essentially using assistive devices or in a wheelchair constantly. After osseointegration for her, this changed her life. So she's now able to clip on and clip off. Her gait is fantastic, and she's able to do all the things that are listed here, hiking over 3 miles, swimming, scuba diving, and off antidepressants, which is pretty huge. So how do we ensure success with osseointegration? Osseointegration is not for every patient. I am not the surgeon that's here to tell you all that every patient should be evaluated for osseointegration. There are many patients who are evaluated by our program who I say, you are doing fantastic. You have a well-fitting socket, you don't have wound breakdown, you're an extreme athlete, you're wearing it 12 hours a day. I don't think this is in your best interest. So it's really about understanding the goals. I think the patient examples that I gave, someone who's not able to wear a socket at all, wound breakdown, constant pain. These are the that have failed multiple sockets. These are the patients that we want to talk to and counsel and work with you to find that patient population that's right for this technique. It's super important that you have a well-trained team with an interdisciplinary approach. That's orthopedic surgeon that has a lot of experience. We have nurse practitioners who scrub the surgery, see patients in clinics. We have physical medicine and rehabilitation doctors who are phenomenal, like Dr. Danielle Melton, who's here today. Our prosthetists and OI peers who can counsel these patients and tell them, and answer questions like I can't or answer, and make sure it's right for them. And we really have to be dedicated to research and figuring out how to do this better, more safely, and get it approved with insurance companies and all of those sorts of things. I think that, and that's something I know that Chris is going to talk about in a minute. So the major inclusion criteria is they have to be skeletally mature, difficulty with use, socket use, and at least for our program, some people are advocating that that's not something that needs to happen. I don't think that that's the case. Transfemoral, transtibial, and humeral amputation in our practice currently. Major exclusion criteria are peripheral vascular disease, any sort of tobacco use or comorbidity or medication that may affect healing. They come in for this for a preoperative or evaluation in a multidisciplinary fashion and interdisciplinary fashion, surgical, medical, PM&R, prosthetist, physical therapy. It's important to look at it from all lenses. So not only expectations and anatomy, but we want to make sure that we have all of these factors covered for postoperatively. So what happens after surgery? It's important that we have a thorough physical therapy and rehabilitation, a lot of alignment, which Chris will get into. We want to correct, instead of accommodating contractures with a socket, we want to correct those, under-accommodate them, and correct them over time. There are nuances with each technique. I mentioned some of them about the skin penetration site or the stoma, depending on the technique. Pain, drainage, early signs of infection, all things that we want to follow very closely. And really important that we collaborate with the local prosthetists and PCP to make sure that these patients are monitored very closely in their rehabilitation course. Again, this is a lifelong endeavor, so our patients are with us for life. And so we follow them very, very closely, and we have to be a resource for these patients because things will happen, and it is not a static type of procedure. Soft tissue, people gain weight, lose weight. There's all sorts of things that can happen. So postoperatively, there's a progressive gait training depending with both techniques where patients progress with weight bearing and more difficult terrain, gaining better control, and ultimately are walking unassisted without assistive devices. So here's an example of a patient pre-OI. You can see a pretty abnormal gait pattern, and this is a press fit patient, and the slow progression, and it's very critical that we monitor their physical therapy closely so that we start balancing and retraining their gait, so with the goal of ultimately having them walk normally. So what about complications? Our team reviewed 25 clinical studies, including over 1,009 patients. And what were some of the things that we found? So there's a 49% overall complication rate if you group all of these complications together, which means 51% of patients have no complications at all. Complications can be everything from skin penetration site pain or stoma pain to implant failure, loosening, requiring removal. Infection is the greatest risk for complication, but that ranges widely from a superficial skin infection that's easily treated with a one-time course of oral antibiotics to septic loosening, which requires implant removal. What's important to note is that there tends to be the complication rate tends to decrease with experienced teams as their experience improves. Here's a complication from one of our patients, a single-stage transtibia that ultimately developed a little redness and which developed some cellulitis. This was treated with a course of antibiotics and fortunately resolved, and he's now over a year out, infection-free, not on any antibiotics. So just because someone gets an infection, it doesn't mean that all is lost, things need to be removed or anything like that. More complicated cases are when this case, where a patient who had their surgery originally performed in Australia in 2016 developed this chronic draining sinus tract and osteomyelitis. So upon closer inspection in the bone, we see some ascending infection and loosening of his implant. But that does not mean that, all is lost either. We address that with implant removal and eradication of infection and ultimately reimplantation. Research is super important because of all the things that I just talked about, right? Dr. Cain mentioned many things the benefits of osseointegration. Our own lab has shown that how much the +M score statistically improves, where patients who have difficulty, like on the left, wearing a socket prosthesis, use their prosthesis longer. The activities balance, balance confidence improves. How disabled patients feel improves significantly. Our gait biomechanics improve. We have these patients develop a more symmetric gait. They return to normal. There is a lot of room for research that we're going to have to focus on, specifically in the diabetic and vascular paths, which are the largest amputee population in the world. Lots of clinical trials and improvements in innovation and technology coming online. The ability to harness the existing neural network and function myoelectric limbs is there. We're working on that. There's much, much more to come. So in summary, osseointegration is a game changer for some. It's not for everyone, but we need to partner together to find who those right patients are and continue to do research to further this technology, because it's here to stay. This couldn't be done without this team, and these people I'm super thankful for. Thank you very much.
We chose this creative profession to improve the quality of life for those with limb loss. And thanks to my early mentors, my single most passion has been socket design, with the premise that a well-fitting socket can be the difference between a happy marriage and a broken one, a productive employee and unemployment, and a Paralympic athlete and a couch potato. We are that difference. While our profession navigates down this blurry road trying to understand what total surface bearing is via contourless sockets, prefabricated systems, sockets by numbers, and direct sockets, amputees with challenging limbs are searching for and finding solutions. And one of these is osseointegration. Osseointegration is an exciting, controversial, high-risk, high-reward procedure that significantly improves the lives of the majority of amputees who undergo this elective surgery. You've heard this before. There's just under 2,000 amputees in the world with osseointegration. And some people are saying, well, this is going to destroy our profession as prosthetists. Well, don't forget, there's 99.9% of the patients that still are wearing sockets. And that will be here for quite some time. ABC's made a statement about our role in osseointegration, and osseointegration has been approved for our scope of practice. We are allowed to see osseointegration patients with two minor caveats, and that is, it does not include the independent provision of invasive procedures, and the prosthetist must follow the specific manufacturer's guidelines for the use of the connector associated with the OI component. We've seen this before. You simply need to know, as Jeff said, need to know the difference between a screw fit and a press fit implant. When somebody walks in your door, it'll be obvious that the screw fit implant has a 14 millimeter abutment, and you'll see various press fit implants. That's the important thing we're all going to need to learn, is there are multiple connectors for press fit, and that's what we'll probably have to get some education to teach you about the various options available. But our scope of practice on the AOPA system, the surgeon takes care of the fixture and the abutment, and we take care of the connector called the axor and the distal componentry. The press fit is a little bit different in that the surgeon takes care of the implant and the dual cone, and we apply the abutment, one of several different shapes, in the female connector, and then the prosthetic components down below. The press fit, there is a gray area here, and that is where I showed. There's a screw that attaches the dual cone into the implant, and we as an organization have to decide if that's the surgeon's role or our role. I truly believe it's our role because when they leave a center of excellence, such as the University of Colorado, they're going back to Alabama, they're going back to Seattle, and I don't think they're going to find an orthopedic surgeon or a PM&R doc to tighten the screw. So I think we need to actually use that as part of our scope of practice. We need to tighten that screw. That's the only gray area that I see. When Dr. Stoneback gives the patient the green light for OI, I call the local prosthetist and I ask them, first of all, are you willing to see osseointegration? If they say yes, then I provide introductory education for them, what type of implant they're going to receive, what type of connector, the rehab process, and then we go over the patient's individual componentry. Number one, to make sure they're safe. If it's a C leg, make sure it gets serviced before they go for osseointegration. And then, is there sufficient room? Is there sufficient build height with the hardware that Dr. Stoneback's going to put in, and then the connectors that I need? Is there sufficient room, including a torque absorber? It's not mandatory around the world. Some prosthetists are recommending them. On our team, I'm highly recommending that we minimize the torsional forces between the implant and the skeletal anatomy, and we've been very successful with that. I like Bob Gailey presented something a couple years ago, and I had to find this, that Mancini in 2016 said that geriatrics turn 866 times per day. I've always been a proponent of torque absorbers, and with osseointegration, especially within the first year, I highly recommend using them. When I talk to the prosthetist, I get 5 different responses, and I understand why I get 5 different responses. The first one is, I'm excited and willing to work with OI clients immediately. The second one says, I'm willing to work with OI clients, but I need a formal education. And I don't know if there is formal education yet, but hopefully we can begin that perhaps in the spring. The third group says, I'm not interested in OI care due to liability. The fourth says, I'm not interested in OI care due to reimbursement. And the last group says, my employer won't allow me to work with non-FDA approved osseointegration. After 40 years of fitting limbs in sockets, when a patient comes to me with a desire to do something crazy, I've always said, and I think most of us are like this, why not? Let's try it, including any one of these activities, from low, moderate to high activities. The most difficult thing for me in osseointegration is that now I finally have to say no. High-impact activities are discouraged, and this is really difficult for me. So, as everyone said here in the group, osseointegration is not for everyone. It was designed initially for challenging limbs, and probably, I'm going to make up a number here, but probably 33% of our patients come to our clinic with extremely challenging limbs. The other part that's difficult for me, because I love sockets, is sometimes we see a great residual limb shape, a knee dysartic, a good, long, strong limb, and the socket design was improper, and that's why patients are coming to us for osseointegration. So you don't have to simply go from being an unhappy patient to OI. You could go to a different step, and don't take this wrong, but that if a prosthetist is struggling with 5 sockets and they're unsuccessful, maybe that patient does have to go to a different prosthetist. Jeff did the same thing with me. He stuck with me for 22 years, but when we found this problem, he said, hey, let's see if it's just your hand skills, and thank God it wasn't. But talking about reimbursement, look at these limbs. You're not going to make money fitting these patients. You might be able to make them happy, but you're not going to be reimbursed properly. I'm happy to say few of my patients have desired to look at osseointegration, but I work pretty hard. I'm not making any profit off of patients like this, but you're going to make their quality of life superior. These challenging limbs can do extremely well with OI. As Dr. Stoneback said, He does a stage 1 surgery on day 1. 6 weeks later, with press fit, he does a second stage to create the stoma, and 2 days later, I'm putting on the abutment componentry and the rehab process begins. The patient stays with us for 3 weeks intensely. They have physical therapy 4 days a week, and I see them 2 to 3 days out of those 3 weeks. I'm sorry, 2 to 3 days a week for the 3 weeks. And it's amazing to see their progress in 3 weeks. But they leave us with bilateral crutches or bilateral canes in either a 2 or 3 point gait, and then we send them back home to you. And it's really important to continue this process. We communicate closely with you. We want to make sure that if they have a flexion contracture and need adjustments, that you do them, because there's nothing better than you get the frosting on the cake. When they eliminate their crutches and they're walking dynamically is when you get to have fun and do the small little tweaking. The height will be excellent when they leave us, but until they can rotate their pelvis and eliminate the walking aids, that's when you get to do your magic. If you're going to be involved in osseointegration, you do need to be able to identify the specific implants, connectors, and manufacturer's instructions for use, including whether they're MRI compatible or not. If you don't know that, you can always call me and I'll let you know if they are. The screw fit implant, or OPRA, has one of 2 connectors. One is a initial loading pylon, or an initial connector that attaches with two 4-millimeter screws, and that's called the training connector used in the initial rehab. Once the patient's approved for a full-length prosthesis, then the Axor 2 is used. These are fairly expensive devices and should be replaced every 5 years. You rotate counterclockwise to insert the abutment and then tightening clockwise. The press fit system includes an implant and a specialized cylinder called a dual cone. It's conical on both ends. It's called a Morse taper, and what holds that dual cone into the implant is a dual cone locking screw, and then on the end of that is one of several different taper sleeves, and that taper sleeve is held in place with a taper sleeve screw. A more simple approach, and the reason why I'm showing you this, is if you're going to work with us with osseointegration, or I'm going to work with you with osseointegration, it's important to know these 2 screws. We will definitely tighten the outer screw, and then we do again have to make a decision on whose role is it for that internal dual cone screw. The manufacturers say it's the surgeon's role, but again, that's not reality in my opinion. And what we're seeing is these screws are loosening very soon within the first 14 months of rehab. We've been following this, and every 2 months I'm recommending you tighten these screws, and after about 14 months we see stability, and then you can tighten them every 6 months. This is going to be the difficult part for most prosthetists, and I think I need to develop like an OI calendar and every year send one out to you guys and say, here are the connectors, here's the IFUs, here is the torque settings. So emergently, if somebody walks into your office, you'll know exactly how to tighten these and take care of these patients, if you're willing. Fail-safes. Most of these connectors have a fail-safe. I think the University of Utah is the only group that says we do, and maybe it's been changed, but they don't need a fail-safe device. They haven't found it to be necessary for their POP system. But the Axor 2 has 2 fail-safes, one in the transverse rotational, to a transverse plane to minimize rotational forces or to break away if there's excessive forces. And then the press fit systems only have fail-safes in transverse plane rotational forces. Most of the press fit implants released at about 45 Newton meters. There are some, including the German ESCA system, that is adjustable based upon the patient's weight. You'll need to know how to service, troubleshoot, and replace OI components. And this is going to be mandatory, I think. When you tighten a screw, you need a stabilization device. The device on the left, it's called a propeller, but I only use one of the arms. We want to stabilize the implant while we're tightening the screw, and we use a digital torque wrench. A click torque wrench isn't very friendly. It's almost like you're not really thinking that osteoperception it could be a problem. When you use a click torque wrench, it usually vibrates straight up to their teeth. So we like to use a digital torque wrench. There's a dual cone. one of several dual cones, and that pin slides right along the channel. I'm sorry, there's a taper sleeve sliding onto the dual cone, and then we attach the dual cone with a taper sleeve screw. I said it backwards. We attach the taper sleeve with a taper sleeve screw. When the patient leaves the University of Colorado, I call the prosthetist and say, would you like to do a FaceTime visit? And I will answer any questions. I will talk about the specifics of the individual patient, and then we'll go over how to tighten the screws. And here, this is very common. This is a great prosthetist from San Francisco, and he's actually asked me to do this 3 times on the same patient because he's not comfortable doing it on his own yet. I'm happy to do that for you. Our patients leave with a toolkit. Should I be giving a patient a toolkit? I don't know. But I'm confident that they're supposed to bring that toolkit to you, and that way you have all the tools available. When you start seeing more than 2 OI patients, it might be time to purchase your own toolkit, and it's very simple. I actually create the one on the right. The left one is a special one from Australia, and that includes a stabilization tools plus a removal kit. It's called a puller, so that you can take on and off the abutment. I also give them a passport so that they can hand this to you and you'll have every bit of information. If you don't mind sitting and looking at this painful piece of paper, you can actually see what kind of implant they have, how long the warranty is, how long the expected use is, which tools you need to tighten, the torque settings, whether it needs Loctite or not, and then how often to tighten these screws. At the very bottom is telling you whether it's MRI compatible or not. And that will be in their toolkit. I also send it to them so they can put it on their phone, so if they're traveling in Greece and they have an emergency, they know how to resolve any issues. Alignment is extremely important in osseointegration. There are many benefits to eliminating a socket, we know that. But 2 of the ones that make me the happiest probably is control. The femur, the skeletal stability is as good as it gets. And I've spent 40 years trying to stabilize bony anatomy within sockets. One of the other benefits is repeatability in donning. How much time have we spent trying to teach patients how to don an above-knee prosthesis properly? That's now not important. Coronal alignment is so easy with above knee as long as you predict the adduction and simply adduct that limb until the pylon is vertical in mid-stance, and when you take an x-ray, your femur is in normal adduction. Here we take x-rays at least twice in the 3 weeks they're at the University of Colorado. We make sure the pelvis is level by looking at the iliac crests or the ischial tuberosities. We start off with the knee center of the prosthesis 25 millimeters above the joint space, but more importantly is when the patient's sitting, the thigh lengths are congruent. And what's also very nice to see is that you actually see congruency in the mechanical axis of the hip, knee, and ankle. To confirm our alignment or to help problem solve, we like to use the laser posture or the laser posture 3D. And here we see great alignment on the first 2 pictures, and on the right, we can actually see that this patient needs increased socket flexion and then a larger offset adapter to move the weight line anteriorly. And we couldn't do that seeing these invisible ground reaction forces. In these early stages, they're not walking yet. They're shifting their weight. Probably 8 days from now, when they start walking, I could have predicted this alignment, but I can actually predict it right now looking at the ground reaction forces that are basically invisible to me. Dr. Stoneback talked about build height and how we have to work together. If we know the patient's limb length, we can actually work together. I can help Dr. Stoneback with the length of the dual cone, and he can tell me where he's going to amputate so that I can help you decide, will those components fit underneath that patient? And do we need to actually get a new foot? Because again, I'm asking for a torque absorber. So I look from right to left. I know the patient's going to be perhaps on a C-leg. Does the patient demand a positional rotator? Most of them do now. What offsets am I going to need? Which connector am I going to need? And then we can fill in the blanks and help each other to say, sorry, we're going to need a new foot. We're going to need a new, which type of torque absorber can fit underneath that patient. That's a small space to deal with. Most surgeons are choosing about 14 to 16 centimeters proximal to the joint space for the amputation level if they have that choice. And that's a small space for us to put an implant, the end of the implant, a connector, offset adapters, and a positional rotator. So if you're going to be doing acute OI care, it's good to have every low-profile component available to you. Sometimes we do cohorts of 6 patients in one day, and I got to tell you, I know I'm getting old, but that's a lot of work to fit 6 patients in one day with OI when I have an hour and a half to get to fit within that small area. The sagittal plane is the fun one because it's dynamic. The patients come to us weak. They have the most significant flexion contracture they probably will ever have for the rest of their lives because they've been sitting on the rear end for 6 weeks. In the AOPA case, they've been sitting on their rear ends for 4 to 7 months. So we're seeing a huge contracture that has to be reduced, but we have to accommodate it initially, and as Dr. Stoneback said, accommodate it minus a little bit because we want them to extend, we want that contracture to reduce. Guess what though, we're missing a socket, and it's very hard for prosthetists to look at our alignment. I simply take a Thomas test, a flexion angle, and there's nothing more magical than putting a digital goniometer on an implant. We know exactly where that femur is now, so we can measure flexion repeatedly, and we can see that a patient that comes into our clinic at 22 degrees on day 1, 10 days, it's reduced to about 14 degrees, and last week we had a patient within 3 weeks go from 22 degrees to -2 degrees. And that prosthetist has to maintain that alignment or continue to follow as the patient's stretching. You can see in the middle picture here, I use a telescopic device basically to measure from the greater trochanter to the knee center to help me predict my alignment. If I don't have a socket, I can see, wow, this alignment is terrible. I can actually put a devil level goniometer or a digital goniometer on top of my connector at the patient's flexion angle, drop a plumb line, and I can see I'm going to need to shift this patient forward. And here is a couple examples on the right. We have different offsets from 0 to 20 to 40 to 60 millimeters. And here's a digital goniometer on the patient. A short residual limb. Don't forget the femur has anterior bowing to it. So a short residual limb with a 21-degree flexion contracture and a long dual cone. What do all these have? What do these all have to do with my alignment? It's putting the alignment of the connector that far anterior. So we have to have offsets. A lot of people are concerned, should we have offsets? Do we need them? It's individual, each case is individual, but you're going to see in the next slide, we have to have some type of an offset. Here's a femur on top of a 3R80 knee, and that's in an anatomical position. You can see the anterior bowing of the femur if we're going to amputate, that connection is going to be anterior to the weight line. Offsets are important. The transtibial picture here, you can see that the tibia is anterior to our normal AP weight-bearing line, and you can see where the connector of the foot is. We need probably a 20 millimeter posterior offset for this patient. If you look real closely, it's probably a bad picture, but that blue tape down there, I actually put 3 different feet in. I put a Freedom Promenade foot. This is a Velocity foot that's in there now, and there's a ProFlex LP. And I marked the different starting points for the pyramids. So every time you're going to change feet, you may need a different offset because the pyramid starting point, if that makes sense, on the feet are different. If you're going to do osseointegration, you need to understand we have significant control over pain with our alignment. Sorry, medial knee pain is quite common in the transtibial level, especially in the early stages when they're weak. We also see anterior knee pain, and it's significant, but with a minor alignment change, we can eliminate that oftentimes within minutes. So if you do have pain, let's talk. Let's look at your alignment. Typically, the answer for medial knee pain is to outset the foot, 3 to 5 millimeters, perhaps more. If you saw Jeff Cain's x-rays, didn't you think that was kind of wild? But his feet were anatomically placed under his hip and his knee, and that's what we're looking for. And we like to use the laser posture for this. The Australians truly believe in this. With this laser posture, you want the load line to the lateral pole of the patella, using the laser posture 2D. Understand the impact of shock attenuation on bone-anchored prostheses. Osseoperception is absolutely wonderful. I keep hearing positive comments about it, but we're also seeing there are some negatives. Jeff came back from Australia and couldn't ride a bike on a gravel road for about 6 months. He went four-wheel driving with his girlfriend, and he actually said, "You drive, I'm taking my legs off." But that went away over time. That's different for every person, but the direct skeletal attachment offers improved sensory feedback to increase the awareness of surroundings. But you can also hear the click of a microprocessor knee. You can hear the click of a DuraShock that's going out. So the negatives are that the patient can feel every click, clunk, and rub, and the disadvantage is the first thing the patients think of, is that my implant? And that's a very anxious feeling. We did fit a patient with a ProFlex pivot foot from Arizona. Wonderful gentleman in a socket. He absolutely loved that foot. When we fit him in with osseointegration, he said, "I can't tolerate it. I think the energy storage rebound, the vibratory motion was driving him crazy." So you will discover that components have a huge effect on discomfort. At the above knee level, ground reaction forces through the skeleton can create significant regional pain. We don't know why, but there's about maybe 20% of our patients, after about 6 months to a year, had significant pain, and we didn't know what to do with it. A couple of patients came to me and said, "I think I want my implant explanted." And I said, "Well, just stick with me for a few weeks. Let's try some things." I hate to say this, but a year and a half ago, I never enjoyed working with hydraulic ankles, but we started playing with hydraulic ankles on these patients with vertical shock, and it's amazing that we're eliminating pain in 1 hour to maybe 3 days. Significant pain where they wanted their implant removed is now completely gone. And this is way over my head, but I have to include this. Jeff has a chromium cobalt implant, which has a stiffness that's much more, how do I say this? It's much stiffer than titanium. This is out of my league. I'm a prosthetist. I shouldn't, but I think the ideal implant is something that matches the stiffness of the bone. So something, maybe a custom-made titanium implant that matches the exact stiffness, because maybe that's the sensation that these patients are getting, that we need to soften by soft, smooth feet, quiet feet. This is Jeff, December, I can't believe I remember this date, December 9th last year. He came to me saying, "My step count's going down and I'm having some distal tibia pain on my left side." And I was having such good luck with hydraulic ankles and vertical shock systems. We put him on an Echelon VT, and he could probably tell you better than I am, but his step counts significantly went up. He did it in a controlled manner, but over the next 2 to 3 months, his step counts went up to?
Double. Average 6,000 a day,
Yeah.
with peaks of 10, 12. And that was the first time, literally the first 10 minutes on that foot.
Yeah. If you guys can remember this, I don't know if I do it all the time, but if you know your patient's going for osseointegration, turn on your activity monitors on the knee for us. It only lasts 6 months, but this is free information. This is a patient pre-osseointegration, and this is on a microprocessor knee from Ottobock. And you can see that he had a painful distal femur in his socket. His average step count was 878 steps, pre-OI. His variability of walking, it's still changing, 43%, that's decent. That number, the proportion of steps with stance phase flexion, this is something we need to study. I don't know if you check these all the time. I'd love to talk to everybody and say, what is your average number of steps with stance phase flexion? I fit a lot of transfemoral patients, and I'm typically seeing maybe 20 to 30% pre-OI. And you can see the speed of walking. Most of my patients typically walk in the first 3 columns, slow, medium, a little bit faster. Here's a patient of ours that just came back to us 2 weeks ago. This is 4 months after his surgery, and the classic x-ray showing the femur in abduction. As soon as he has osseointegration, the femur is in awesome adduction. and the mechanical axis of the hip, knee, and ankle are symmetrical. But now you see the numbers here post-OI. His step count is only 3,600, but let's not forget that he was in rehab. So he's still, the first 2 months, he was still probably doing 1,800 steps, and the last 2 months, he's now probably doing 6,000 steps. But the variability of walking speed, 76%. The proportion of steps with stance flexion. With ROI patients, I'm seeing 60, 70, 80%. And I believe that's due to the control of the femur directly connected to the knee. And we're getting incredible control, both in the ML plane, and we were never getting it in sockets that were trying to stabilize the femur. We were stabilizing in the ML plane, but it was very difficult to stabilize the femur in the AP plane. And look at the speed of walking. Most of our ROI patients are now in the 4th, 5th, and 6th columns for speed. Be ready for adverse events. Jeff probably hasn't seen this picture in 5 years. Jeff came back from Australia and tightened the screw too much and stripped it. And I've never had to put a human being in a vise before. But if you want to do it, he's the guy to do it. But yeah, he came in here and I literally had to lock him up in a vise and take off the parts. But osseointegration, when things are good, they're very good. But you're going to see some things in your life that you'll be shocked, probably shocked about. Dr. Stoneback, at times, I know Dr. Almuderis is, Nikki's in the room. I think to drill out a dual cone, if it breaks, possibly 11 to 12 hours in the OR. I can't imagine anything worse.
Yeah, being in a patient, 11, 12 hours.
Shower componentry. For the first time in my career, we were fitting shower componentry in the 80s, but we were never getting reimbursed for it, and they were basic systems. But shower componentry is now getting authorized because these patients have to wash their stoma twice a day, and we don't recommend them taking a bath because of hygienic purposes. So we're getting shower legs approved, both at the transtibial and transfemoral levels. And whatever these patients do on their spare time with those shower legs is not my responsibility. That is Nikki on the right there. Cosmesis, quite important for males and females. They want to cover that space that's the void between the thigh and the knee. People are making them themselves. What I worry about, though, is hygiene for the stoma. I wouldn't want one of these on a limb in Miami 18 hours a day in a hot, humid environment. So I think that we're all going to be working on something like this, but I think they should be perforated to allow the stoma to breathe. Reimbursement. Osseointegration is a chance for us to probably change our L-coding system because we are not providing sockets anymore. And unfortunately, our broken L-code system, we only get paid for a product, not a service. So I think this is a great opportunity to use osseointegration to go to DMERC and to PDAC and say, it's time to change our broken system. Here on the left are the codes for a transfemoral socket, and on the right, what you're not going to get covered, and then the two extra items at the bottom that you will get covered for. And that is a quick disconnect and a connector. The connector is an L5999. Many different regions struggle getting paid for those, but when my wife and I joined the osseointegration team at the University of Colorado, we knew we'd have to be pioneers in a lot of different things, but we had to be pioneers in billing. And I have to say there's been a lot of struggles, but we have been very successful billing for osseointegration components, but we do need a code. The tough part for me is when you do the servicing and the repair, an L7520 isn't going to get you reimbursed for your liability, for your education, for your expertise. So those are the things we need to work on. Real quickly, the future, educational seminars. Let's start doing it. If there's interest, let's do it. But if you're going to see one patient every 3 years, I can probably educate you one-on-one. I think I'd like to start an osseointegration society because there's so much. I had to literally dilute my presentation from about 9,000 slides down to about 50. So there's so much information I can share with you. And then it's time to unite. I don't know if we need to spend money and get a lobbyist like the physical therapy did, but physical therapy has a code for gait training, and we don't. And who does most of the gait training? And in prosthetics. Thanks, and I welcome your comments.
So if we have any questions, please step up to the center microphone because this session is being recorded. We have about 10 to 12 minutes for questions.
My question is about the longevity of OI with patients as they age and the concerns with bone density and the structural integrity of that connection and using the prosthetics.
That's a great question. So there's over 20-year outcome data that's available. So the longevity is there, and what's very interesting is that patients who are osteopenic or have poor bone quality, they actually build bone. Because if you're talking about a transfemoral amputee within an ischial-bearing socket, they're not loading their bone. So you can see side to side a significant decrease in bone quality, and then it will build back because they're actually loading that bone, and the bone responds. So.
The other thing that research is showing is that because they're doing more steps and more active, they're actually also having better bone density to other bones in their body, like their spinal bones.
An interesting, talking about age, that's a great.
You're not allowed to talk.
Chris is cut off.
Last night, too. One of the interesting things about age is the tissue. The tissue, as we age, the tissue is going to hang down, and that could be a problem in the future for stomas, only because firm muscle over 15 to 20 years, we'll have to see what happens to these stomas. They might need a tummy tuck or something like that as they get weaker, or tissue is becoming weaker.
Yeah, so we have had patients that become more active, exercise, and lose weight. And so their soft tissue envelope can change. And so that's where a really good plastic surgeon who can address those issues, like Chris said, like a tummy tuck, a residual limb tuck, sometimes is necessary, but it's pretty successful.
I've got two questions. The first one, with the incidence of explant in this device, and I know there's probably a lot of different reasons between infection or acceptance or whatever the case may be, how often are you seeing a significant length reduction in the bony component?
That's a great question. Very rarely. So the majority of the time, if we have to explant someone who has ascending infection, what we do it in a manner that really takes only infected bone away. So now at the distal end of the residual limb, if they have some compromised bone, that may need to be debrided, but that may be less than a centimeter. And then we can core out, if you will, the intramedullary canal, like in a femur or a tibia, treat the infection, usually, and shortening is usually not necessary, at least very much. Close the soft tissue envelope, and I gave an example where we didn't shorten him very much and came back and reimplanted him. So we always counsel patients, there is a chance that you may need to be explanted, or we have to go to a higher level amputation. That's one of the risks, but fortunately that's very, very rare.
And then secondly, when they're ready to weight bear for the first time, what are you hearing back as immediate response from the sensation of initial weight bearing?
So what we find is, number one, once we put the intramedullary implant into the bone and it is brought through the skin, it can be like a lightning rod, because they're now getting osseoperception and feedback from that. So we counsel on them and warn them that may occur, and it can be unsettling at first because it's a lot of their feeling. And so then, fortunately, that then tends to mitigate. With load bearing, there's people are all over the board. No pain at all to some pain. A frequent complaint will be pain with offloading, and we associate that more with soft tissues, muscular attachments. and then it slowly gets better. You can answer better than that.
It really does feel part of you. That's a different way of saying that, where you know where your foot is, you tap on the foot and you feel it differently. An above knee, you can tap on the top of, and they'll say, oh, you're tapping on my foot, other places. Over time, that vibratory sensation got better, but the first, again, few months, I couldn't ride my bike on gravel, so.
I'm sorry, I forget your, I even forget your issue.
Actually, and it's funny because when I go to the Amputee Coalition and sit in the room with the other bilateral BKs and they start talking about the challenges of being a bilateral BK, I don't have 80% of the problems that they're talking about. So it's a different kind of a feel.
I get to be there for every fitting when they do stand up for the first time. I highly recommend that they have their spouse subtly, without the patient knowing it, videotape, because it's an awesome opportunity that 99% of the patients, I don't see that pain until they start pushing off of the toe or landing on the heel. But vertical loading, it brings tears to most people's eyes and said, this is just bizarre, this is fantastic, it's extremely positive.
Yeah.
Extremely positive.
What happens if the patient needs to have a hip or a knee replacement?
Great question. So that's something that's part of our initial evaluation radiographically and clinically. And if they have a hip is the most common area where we'll see some early arthritic change, we'll counsel them. We have a consultation with a hip replacement specialist that works with the limb restoration program, who's accustomed to dealing with more complicated situations, and we will plan the implant accordingly. So leave room. There are resurfacing options. There are also options where if we leave enough room, they can get a custom implant designed for the hip replacement.
Thank you.
Very nice team presentation. As an occupational therapist, I wonder if you could comment a bit on your experience with transhumeral OI. Specifically, how many you've done. Is it single or double stage? And then is there a defined OT protocol afterwards?
Great question. We are in the process of building that. We have had several patients who are candidates, and we have several patients who are candidates. Currently, we are having, we're in discussions with implant device makers about using these implants in that fashion and all the componentry that goes with it. So that's coming.
Right, so you haven't done any thus far, is that
No.
correct? Okay. It's my understanding the majority, if not all, have been done at Walter Reed.
Correct.
Okay, and we're waiting to move into
Yes, ma'am.
another series of, yes,
Mhm.
familiar with that. Okay, thank you very much.
Mhm.
Excellent presentation. Thank you so much. Miguel Gomez from Colombia. I am a trauma surgeon, but also I am a CEO here in the States. Unfortunately, in my country, we still have a lot of amputees by landmines. And that's a terrible situation. Young people from 18 to 30 years old. And I was wondering if in the first surgery that is through a landmine or gunshot, can you perform the surgery to make the myolisis and the myoplastia properly? Of course, you have to deal with infection because maybe it's infected. But it will be nice if you can do that. And secondly, definitely we need to have training. So I will go to my country and tell the people, hey, there are space or there are a hospital or there are a team that will be training you because we have a lot of amputees, young people.
So are you asking about doing osseointegration during the initial amputation, or how do you prepare an amputated limb for osseointegration in the future? Okay. So first of all, I do not recommend doing osseointegration as an initial amputation step for a couple reasons. Number one is in any trauma, especially in a traumatic situation, infection risk can compromise the outcome long term. The second reason is that osseointegration is not for everyone. So patients may do very well with a socket prosthesis and don't need it. They're really, so I think that's, and there's a component of this where patients who have been through socket wear, in my experience, just like Jeff did really well for a long period of time and then reached a point where he wasn't doing well, he's had some complications that he's experienced. But I think that when you ask him, you know, is it still better than a socket? The answer is yes.
I'm going to take a jump. If I had my best treatment option, I would fly to France and go to Lourdes, drink the holy water, and my feet would grow back. The second best would be to invent a time machine and go back about 15 years, and I could wear the sockets that I had with Chris. But if I'm comparing where my life was when I chose to have the osseointegration and now, there's no comparison. Even the time I was during the recovery from the infection and the debridement, Pat said, look, even now, and it's the worst you've been since you had osseointegration, you're better than you were before. And so that's the thing to remember there. You're not comparing your best outcome, you're comparing a person usually that's had a challenge with the socket.
And then to answer your question about training, so I have surgeons from all over the world coming to learn how we do things and train, and so I'd be happy to coordinate with you if you want to meet afterwards.
If I could just add, if they can't go to osseointegration, and this might be controversial, I might recommend getting proficient at a natural physiological Erdl procedure. I still think that it's a dying art because I think that orthopedic surgeons, and I hope osseointegration doesn't take that route. Dr. Stoneback said we need expert surgery to continue with osseointegration, and unfortunately the Erdl procedure took a different channel. And orthopedic surgeons started modifying it with unanatomical shapes, and now it's got a relatively bad name. And I think if we went back to the original Erdl procedure for your young patients, I would highly recommend that as a preparation for OI.
Hi, I'm going to concur. It was a great presentation. I have two questions. The first one's real simple. Maybe I missed it, but when you were talking about the two types of integration, the screw type versus the press type, you mentioned that the screw type had a 220-pound limit. Does the press type have a limit too? I didn't see it, but.
So there is not a limit for the actual intramedullary implant. It's for the various connectors. So depending on your connector is your weight limit.
Right, and that's 275 pounds for the German and the Dutch connectors that we use.
Right, so if you've been to America, I don't know if they'll work very Yeah. So my other question, and this is more for the future. I actually have a patient who, she's a police officer, and she had a run-in with an 18-wheeler, and she's got a very, very unusual amputation. It looked like some of your pictures you had there. We're about to actually start trying to do her first fitting, but I'm a little concerned about how it's going. And I've actually been thinking about osseointegration for the first time in my whole career. So seeing you guys here has been fantastic. I have a metric ton of questions that I can't ask you. How would I contact you guys to follow up with you?
If you just grab us afterwards, we'll give you our contact information. We're happy to help you in any way we can.
We use cards. It's a data storage, but it's compressed, yeah. Trees.
Thank you, appreciate it.
Hi, I'm currently a resident, and I have questions on insurance coverage of osseointegration and what we can do as prosthetists to help document everything to get them as closer to osseointegration.
Great question. So the important things to document are all of their difficulties and how many sockets they've failed, and falls, fractures. These are the things that are important, right? So the more, just all of those factors are important. So it's about the lack of safety in their current environment, their persistent wound breakdown and needing to have antibiotics or infections, all of those sorts of things. So those are the things that you can put in your documentation that will help.
Thank you.
Last question, thank you.
Hey, thanks. This is a great presentation, guys. Can you speak to you said, I think on one of the slides it said custom implants. Is that like a patient bespoke one-off implant based on a certain surgical need? And like how often is that being implemented?
Yes. So their custom devices are a powerful tool. So I'll give you some examples that I didn't show. So I have a patient that had a sarcoma and they were missing the anterior third of their femur. So they have a very short femur and they don't have an anterior cortex. So they don't actually have an intramedullary canal. The way we addressed that was with fibular strut allograft, so donor bone, and then took the inside of their healthy femur on the contralateral extremity and created a bone graft bed of bone graft, and then custom made an implant that was very short and protected. I think Chris showed his x-ray that has a cephalomedullary screw that protects the femoral neck and head from fracture. So that's one example. We have another patient that had a tibia, so they had infection of their femur. It's a long story, but basically their sciatic nerve does not function. They were missing about half of their femur, and their knee and foot didn't work, and they couldn't feel it. So we amputated the distal femur, the knee, the proximal tibia, and the ankle, and turned the tibia upside down and connected the distal end of the tibia with intact blood supply to the proximal femur that was only this long in order to create a normal femur, which is an upside down tibia attached to their proximal femur. So that is some complex anatomy, and that's the definition of a custom implant. We're making it to do a transfemoral osseointegration amputee that has an upside down tibia.
What's the approval for that like? Is that like a humanitarian exemption? Sort of
It's a custom device exemption through the FDA.
Thank you all for joining us today. Thank you for your leadership in the field. Thank you as a person that lives with limb loss for the transformative nature of the work that you guys do for my own life. So we're going to be remaining up here for a little while if you'd like to come up and ask any more questions, but we're going to go ahead and close out the session. Thank you all for attending.
That's it. Daniel, get a picture.
Yeah.
Danielle.